Θα ήθελα να σας παρακαλέσω, επειδή είμαστε αρκετά καθυστερημένοι, να προχωρήσουμε. Ακτινοθεραπευτές, σας παρακαλώ. Thank you. This is the last session before the lunch break. We're about 25 minutes late. We will try our best to catch up a bit at the time. And I'm really very happy to co-chair this session with my friend Vasilis Karadakis from Guy's Hospital in England.
Hello. Hello, everybody. It's my pleasure, dear President Vasilis, dear my friend, and we're very happy today to have with us Ms. Christy Russell, who is oncologist, vice president of U.S. Medical Affairs Exact Science Corporation, with a very, very important and interesting lecture, Oncotype DXSA Impact on the Management of Breast Cancer, the past and, of course, the future.
Thank you so much. It's my honor to be invited to Greece, this beautiful country and city. So thank you very much for allowing me to come. I am a medical oncologist. I work for Exact Sciences Corporation, so I have a conflict of interest because Exact is who makes Oncotype. But prior to this position, I was at the University of Southern California for 31 years in Los Angeles and the director of the breast cancer program there. But I'm a medical oncologist, so it's also a bias. All right, let me walk you through Oncotype. You heard one point of view on Oncotype. I'm going to give you a more factual point of view. So when this product came on the market in 2004, it came on originally as prognosis based on women who got tamoxifen versus didn't. But the real question is not a prognostic assay. I think we did really well when we had adjuvant online, which was all the clinical features, and we said people get about a 25% relative benefit from chemotherapy. Here's your risk, here's your chemo benefit. And adjuvant online went adjuvant offline because of the prediction that was seen from Oncotype. So what is prediction? In order to show prediction, you have to have a randomized clinical trial. If you're going to show prediction from chemotherapy, half the patients get chemo, the others do not. It's balanced. And then you have to do a statistical analysis that's a three-way interaction of the chemotherapy, the score, and then whether the patient got benefit or not. So in this case, this is the B20 trial I was spoken about previously. It's an old trial. This is women who are lymph node negative. They received tamoxifen alone or chemotherapy plus tamoxifen. And the overall outcome of the women in this trial are in the purple lines there. And it looks like there's a relative 17 to 20% benefit from chemotherapy in these hormone receptor positive patients. And when we got the blocks from this trial, if you had a low score, which was low at that time, 0 to 17, there was no chemo benefit. If you had a score of 18 to 30, there was no chemotherapy benefit. And all the chemo benefit was sitting in that 31 to 100. Now, that then led to the TAILOR-X trial. Whether you want to believe that this is prediction or not, it is agreed to by multiple guideline groups that this is consistent with prediction and it meets all the criteria for prediction, regardless of other people's personal opinions. TAILOR-X said, okay, it looks like 31 and above, there's a lot of chemo benefit, and there's more equipoise 18 to 30. So why don't we do a big trial that says when you're in that more middle range, where do you start to see chemo benefit? Because there might be some there. They decided to not go 18 to 30. The National Cancer Institute of the United States decided to bring it down to 11 to 25. I don't call any of this low, intermediate, high. This is a continuous score. And the real trial for TAILORx was these patients in the middle. 6,700 node-negative patients, all ER-positive, HER2 negative, and they're randomly assigned to standard of care endocrine therapy with or without chemotherapy. Now, they did not allow this high group to be randomized, and you would have had to have randomized the 26 to 100 if you wanted to see prediction in this trial. If you get rid of the patients who we know have significant chemo benefit, and you don't include them in the randomization, you can't see prediction. But they did power this middle group to say, if we power it big enough, if there's any chemo benefit in that group, maybe we can see it. And what it showed at 9 years on the original presentation is, for the overall 6,700 women, there was no chemotherapy benefit, either for disease-free survival or distant recurrence. But they had an unplanned subset analysis that looked at age. They actually looked at menopause status, they looked at tumor size, they looked at grade, they looked at all the clinical features, said maybe somebody's getting chemotherapy benefit, and it didn't matter what the grade was or the tumor size or put them both together to come up with clinical risk. The only thing they saw was in the younger women, they were getting some chemotherapy benefit in that 11 to 25, where the older women were not. Now you could say that's because a young woman's breast cancer is worse and they just need chemotherapy. Or the open question is this chemotherapy benefit in the 11 to 25 from ovarian function suppression? Is the chemotherapy just suppressing the ovaries and you're just getting a super endocrine effect on top of the tamoxifen they were getting? This trial can't answer the question. It was not a randomized question. So if we take those young women who seem to be getting chemo benefit on that curve and we make this bar graph, these are the original presentations from Sperano, that if you look at 11 to 15, there's no chemo benefit. 16 to 20, we saw a little bit absolute chemo benefit, 1.6% at 9 years, and then 21 to 25, 6.5% chemotherapy benefit. It was pre-decided by the statisticians with this trial that they would take that 11 to 25 and break it into 3 groups so that there were equal number of patients in each group who got chemotherapy and did not. It wasn't to signify that we're establishing new groups of intermediate or high. And then when we added clinical features, so high risk, low risk, the way you tell clinical feature high risk or low risk is the rule of 4. If you add grade and tumor size, and if that number's up to 4, that's low clinical risk. And anything above 4, high clinical risk. So for example, 1.2 centimeter, grade 2, that adds up to 3.2, low clinical risk. 2.2 centimeter, grade 2, 4.2 addition, that's high clinical risk. Everybody in TAILORx had determined whether they were high or low clinical risk. So in the young women who are getting that increasing chemotherapy benefit, especially 16 to 25, when you add clinical risk, here's low and high clinical risk. The low clinical risk, 16 to 20, there's nothing there. The high clinical risk looks like they're getting a fair amount of chemo benefit. And then 21 to 25, it didn't matter whether you were high or low clinical risk. There's a lot of chemotherapy benefit. TAILORx got updated this past year by Sperano again. It's now 12 years of follow-up. The median follow-up is 11 years. When they originally did the 9-year follow-up, the median follow-up was 7.5 years. So now we're at about 11 years of follow-up. And there's a lot more events. So if you just look at distant recurrence, the original presentation at 9 years was 375 events. It's now up to 561. So you're getting a 50% increase in events. So that's why they reanalyzed it. They will continue to reanalyze TAILORx up to 20 years of follow-up. That is in the original funding and statistical plan. So let's look at those young women again, because nothing changed at 12 years. If you were postmenopausal or over 50, you just did not get chemo benefit, 11 to 25. But in the young women, again, we saw that increasing chemo benefit. But the numbers are diminishing a little bit. So 11 to 15, no chemo benefit. 16 to 20, I would say 0.6 chemo benefit at 12 years is not something to write home about. And then 21 to 25, you're really starting to see pretty significant chemotherapy benefit. And then we broke it down again into low and high clinical risk. So if you're 16 to 20, low clinical risk, nothing. High clinical risk, 3.1% chemotherapy benefit. A lot of it seems to be in that 21 to 25, and then presumably 26 to 100, you've got even more. Again, we don't know if this chemo benefits from ovarian suppression or from it's the effect of the chemotherapy on the cancer. Then node-positive breast cancer. So if I say, okay, if you're lymph node negative, 85% of patients have a recurrence score 0 to 25. And 15% of patients have a recurrence score 26 to 100. If you are lymph node positive, 85% of patients are 0 to 25. 26 to 100 is 15% of patients. So it doesn't, having nodal involvement doesn't seem to change the distribution of recurrence scores. We only see it change in very, very young women, under 35 with breast cancer. They tend to ride higher, but still the huge majority are sitting below 25. So responder that you're aware of, 5,000 patients. There's 2 approvals in this trial. You had to sign a consent to say, I consent to have an oncotype. And then if you had a recurrence score 26 to 100, you were off the trial, and those women are not being followed. If your recurrence score is 0 to 25, you had to sign another consent agreeing to be randomized. So with that, the patients are all 0 to 25, 1 to 3 positive lymph nodes, pre- and postmenopausal, and they all get standard of care endocrine therapy with or without chemotherapy. Now, one of the criticisms of this trial is that there's no ovarian function suppression for the young women in this trial. It was not a standard of care when this trial was begun. SOFT had not been reported on yet. And for the women who are postmenopausal, recurrence score 0 to 25, at 5 years, there is no chemotherapy benefit. That's 85% of postmenopausal women, 1 to 3 positive lymph nodes, there's no chemotherapy benefit. That's a huge change from the way we used to approach these women, right? We gave them all chemotherapy. They did look at subgroups, saying, did anybody get chemo benefit? Let's look at grade 1 versus grade 2 or 3. No chemo benefit for the higher grades. T1 versus T2, T3, no chemotherapy benefit. High and low risk. High risk, grade, tumor size, no chemotherapy benefit. They compared 1 positive lymph nodes to 2 to 3 positive lymph nodes, 2 to 3 added together, no chemotherapy benefit. They pre-decided they would take that 0 to 25 and break it in half, 0 to 13 and 14 to 25 for an analysis. It was not for the purpose of setting new parameters or a new low or intermediate or high. And then the premenopausal women all got chemotherapy benefit. And you could say, well, is this enough? For distant recurrence at 5 years, it's 2.4% chemotherapy benefit. I would say the majority of people who've seen these data saying, I think I need to give this patient chemotherapy. She's young, or 50 and younger for the most part. So the question is, did anybody not get chemotherapy benefit who was premenopausal in this trial? And the answer is yes. For the women who were 50 and older and premenopausal, no chemotherapy benefit. 50 and older, premenopausal, no chemo benefit. Everybody else seems to get some chemo benefit. So, responder, postmenopausal women, 0 to 25, that's 85% of postmenopausal women, 1 to 3 positive lymph nodes, will not benefit from chemotherapy. Premenopausal women, other than those who are 50 and older, we can't find a group of women who did not benefit from chemotherapy. All right, so guidelines. So yes, you can tell from my accent I am an American. and I'm going to show you American guidelines, so I apologize. The NCCN guidelines currently say for postmenopausal women who are N0 or N1, 1 to 3 positive lymph nodes, as long as she's node negative and the tumor's over 5 millimeters, NCCN says strongly consider the 21 gene assay. And they say this is the only predictive assay of all the assays that are on the market. And then in postmenopausal women, they use the data from TAILORx and Responder, saying if you're 0 to 25, don't give her chemotherapy. And if she's 26 to 100, you're in the range where you can start to see chemotherapy benefit. For premenopausal women who are node negative, right, we saw that increasing chemo benefit starting around recurrence score of 16. So let me step back and say, for premenopausal women who are node negative, what percentage of them have a recurrence score of 0 to 15, where we see no chemotherapy benefit at all? That's half. Half premenopausal women, node negative. If you do a recurrence score, half will be 0 to 15. There's no benefit from chemotherapy. So in the node negative premenopausal women, NCCN uses the results from TAILORx and makes recommendations. They hedge a little bit on that 16 to 25. They can say you could use chemotherapy followed by endocrine therapy, or if you want to, you just use endocrine therapy alone, or maybe add ovarian function suppression. And I think there it is not a helpful guideline. And then for premenopausal node positive, NCCN is agnostic to all of the assays. They're saying if she's a candidate for chemotherapy, consider using a gene expression assay, because they're all now just prognostic here. We believe that all these women are getting some chemotherapy benefit, I think likely because the chemotherapy is causing ovarian function suppression. It's very prognostic for all the assays. And what it says, though, however, it makes a recommendation for therapy. So if she's premenopausal node positive and you do a score and it's high, you could give her adjuvant chemotherapy or followed by endocrine therapy, or you could just give ovarian suppression and an endocrine therapy, although there's no data to support that point of view. ASCO guidelines were updated in 2022. So you can tell that our company likes purple, but I could say that what ASCO does is doesn't make specific recommendations around therapy. They look at the level of evidence, and then they make a recommendation based on that level of evidence. If you look at premenopausal, you can see that ASCO says no assay should be considered other than oncotype. And they're saying that really only for the node negative. For the node positive, they have a statement saying the oncotype test is prognostic and it could be used for shared patient decision-making around her prognosis. But the strongest recommendation and the highest level of evidence is oncotype in the postmenopausal women and in the premenopausal node-negative women. For MammaPrint, they're saying if you're going to use a MammaPrint, only use it in high clinical risk. So you need to know the rules of high clinical risk. Rule of 4 for node negative. It's a different rule if she's node positive. Do not use it for premenopausal women. For EndoPredict, they're saying that the evidence is intermediate and there's a moderate recommendation to consider using it. Prosigna, only node negative postmenopausal women. And further practice guidelines from ASCO, oncotype is strongly recommended to be used for all node negative and postmenopausal N1 patients. It's the only recommended assay in the node negative premenopausal patients. The recommendation is strong with a high evidence quality, level 1 evidence based on TAILORx and Responder. MammaPrint should not be used for adjuvant endocrine or chemotherapy decisions in patients who are 50 and younger. ASCO is quite clear about that because they all got chemo benefit even if they had a low MammaPrint score. So why are you ordering MammaPrint, high score, low score? They all got chemotherapy benefit. So where are we going in the future? I think this is where we've been in the past. I think we need to improve on all these assays. So what clinical trials are we running to try to answer the data gaps that exist for all those data I just showed you? The first issue is this issue of young women. Is this ovarian function suppression, or is this young woman's breast cancer just needs chemotherapy? These are data from TAILOR-X, and what they show is that by age, this is disease-free survival on the left, distant recurrence on the right. This is hazard ratio of 1. To the right of 1, it was better to be given chemotherapy. So the women who seem to get the best chemotherapy benefit from TAILOR-X are those women who are 46 to 50 and premenopausal. And 41 to 45 look pretty good for distant recurrence, still some benefit, but 40 and younger, no chemo benefit. Why would that be? And the question is it because the younger you are when you get chemotherapy, the less likely it is you'll have permanent ovarian function suppression. So the suggestion is from TAILOR-X, based on, just an analysis of age, is that these women may be getting chemotherapy benefit when they're young because of the effect of chemotherapy on the ovaries. That's not proof, however. And then Responder also did not report yet on blood testing, although it turns out all the premenopausal women have had a blood test with endocrine function. So we'll see that analysis coming up in the next year. So they looked at women who developed amenorrhea. Women in the Responder trial who were premenopausal had to fill out a diary every 6 months to say whether their period stopped or not. And they did that for the 5 years of follow-up. And so what these curves are showing is whether you got endocrine therapy alone, and most of these women were just tamoxifen, or whether you got chemotherapy plus endocrine therapy, the women whose periods stopped are doing 50% better than the women whose periods did not stop. That would suggest to me that some of this is ovarian function suppression, the benefit of chemotherapy. So where is this leading us? This is leading us to the trial just opened last month. Its acronym is Offset Chemo. It stands for Ovarian Function Suppression Endocrine Therapy Chemo. It's an NSABP NRG trial. It will be an international trial. This will put premenopausal women, hormone receptor positive, HER2 negative. If they're node negative, everybody gets a recurrence score here. If they have a recurrence score of 16 to 20, they have to be high clinical risk, or 21 to 25, any clinical risk, or N1. All the patients from TAILOR-X who seem to get chemo benefit, and the patients from Responder, all of whom seem to get chemo benefit. They're going to be stratified by the statisticians up front, and then 4,000 patients will be randomly assigned to ovarian function suppression. Everybody will have their ovaries suppressed, and then it'll be with or without chemotherapy. So we can answer the question. If you're postmenopausal and you have a recurrence score of 21, you don't get chemo benefit. If you're premenopausal, you do. If we shut down your ovaries, do you still get chemo benefit? This trial needs international participation. The PI is Terry Maminis, Greek, who's the head of the breast group at the NSABP. So I think y'all need to call Terry and go, could we please put our patients on this trial? Okay, so the trial, I think, is going to take way too long to accrue. They believe modestly that it might take more than 7 years to accrue. We won't see data for 11 years. That's way too long. This needs to accrue much more rapidly. It's a very important question we have for these young women who I suspect we're giving way too much chemotherapy to, and we would do a better job giving them the appropriate endocrine therapy. How about using the Oncotype for other things? So let's look at this issue of radiation decision-making with the recurrence score. Now, if we go back to Responder, their patients in Responder, they're all 1 to 3 positive lymph nodes, and in many parts of the world, the standard of care is to give regional nodal radiation if your patient has 1 to 3 positive lymph nodes. I don't know what your standards are here. It's very common in the United States to receive supraclav, high axillary, and internal mammary radiation if you have 1 to 3 positive lymph nodes. The women in Responder were not required to have regional nodal radiation. So they went back and did a retrospective review and said, what's the local recurrence rate of women who got regional nodal radiation versus not? Nobody's randomized here, so it is not level 1 evidence. It's all hypothesis generating. So they know the radiation dose. They did an adjusted analysis for menopause status, treatment arm, recurrence score, etc. And here's what it showed. At 5 years, if you got breast-conserving surgery, you got breast radiation, and you got regional nodal radiation, 0.85% have had a local recurrence. If you had a lumpectomy, breast radiation, you did not get regional nodal radiation, 0.55% have had a local recurrence. Not a winning argument for giving regional nodal radiation to everybody. Now, these are patients 0 to 25 recurrence score. You're not in the high range. Mastectomy, with or without regional nodal radiation, so it was chest wall and regional nodal versus no radiation at all. There's a numerical difference here, but these are very, very low local recurrence rates. I would say Oncotype is definitely predictive of chemo benefit, but it's very prognostic for local recurrence as well. So you have to do a trial to answer this question, and that trial is ongoing. So it's a trial called MA39, started by the Canadian Radiation Oncology Group. These are women, 1 to 3 positive lymph nodes, recurrence score 0 to 25, and they're being randomly assigned to regional nodal radiation or not. It's about halfway accrued, but I think just with the discussions you've had about lymph node surgery, adding in regional nodal radiation, the risk of lymphedema, it would be nice to find other prognostic factors that could reduce the amount of radiation that we're delivering to these women if this is a positive trial. And the other trial is a trial called DEBRA, also run by the NSABP and radiation group, is looking at, okay, how about T1 N0 cancers? Do they need breast radiation? So this is a trial of 1,600 women, T1 cancers, recurrence score 0 to 18. That has a very low risk of local recurrence, and they're randomizing to breast radiation or not. It's a randomized trial, so it'll answer the question. I think there'll probably be some small radiation benefit, but we'll see. For this group of women who are 50 to 70 years of age. Now we're getting younger in the question of no radiation. Oncotype is not predictive of radiation benefit. It is not a prediction. It is not a radiation prediction signature. It is prognostic. Okay, what can we do about improving the Oncotype score? Maybe the 21 genes, it's kind of old, it's been around for 20 years. What should we do to improve it? Well, what was indicated earlier is we haven't added clinical features. We actually haven't had to add clinical features. It's very predictive without it, but clinical features do add prognostic information. A woman with an Oncotype score of 10 who has a 1 centimeter cancer or a 4 centimeter cancer has a worse prognosis with a 4 centimeter cancer. Clearly, adding clinical features will change your prognosis. And there's a tool called RS-Clin. Unfortunately, this tool is not available to EU countries for regulatory reasons, although we continue to work to try to make it available. In this case, if your patient's node negative, you get an Oncotype score, you add in her age, tumor size, grade, and it gives you her individualized risk and chemotherapy benefit. So it's more individualized, again, not grouping by high, low. How about, well, maybe we should just do full NGS. Let's do whole exome sequencing, whole transcriptome sequencing of the cancers that are in these trials. Maybe we can do better than the 21 genes. We did that. We did whole exome, whole transcriptome. We could not find a better gene group that was more predictive than the 21 genes. Which is interesting because we really thought we would. It'll help extend the patent out a little bit, but we haven't been able to show it at this point. And finally, how about if we add endocrine sensitivity to the Oncotype? And this is the West German study group's approach to recurrence score and Oncotype to see if we can't find a different group of patients. And so these are the ADAPT trials. This is, I'm sure, very hard for you to see in the back. In the ADAPT trials, you get Oncotype, you get a recurrence score, you get a Ki 67, both are done on the core. you give the patient 3 to 4 weeks of an endocrine therapy, and then you take her to surgery, and you do the Ki-67 again. And if the Ki-67 on the second surgery, on the second specimen, is 10% or less, they're calling those patients endocrine sensitive. So now you have an oncotype, and you have whether she's endocrine sensitive or not. So in this case, on the ADAPT trial, they said, okay, if her recurrence score is under 12, we'll just give her endocrine therapy, whether she's N0 or N1. If her recurrence score is 12 to 25, and she has endocrine sensitivity, we'll just give her endocrine therapy, and we'll compare these two groups. We'll compare the less than 12 to the 12 to 25, but the 12 to 25s have to be endocrine sensitive. And what it shows is they're the same. So you can now say, well, maybe the oncotype score is prognostic, but maybe if you can also prove she's endocrine sensitive, you can find a better group of people at higher recurrence scores. And we saw this whether she was young, 50 and younger, or over 50. So now we've got a group of patients who are node positive in the scores of 12 to 25, where we're seeing chemo benefit from responder, and if you add endocrine sensitivity, maybe not so much chemotherapy benefit. And finally, we have the ADAPT cycle trial. Again, this is a very complicated trial. Oncotype, Ki-67. Give her endocrine therapy for 3 to 4 weeks. Take her to surgery, Ki-67 or not. And now we have different groups. Now we're going to say, okay, if she's N1, but she has a high oncotype, but she's an endocrine responder, we're going to randomize her. Or N2 and 3. Now we're going to take 4 more positive lymph nodes, and if the oncotype's 25 or less, but she's endocrine sensitive, we're going to randomize her. What is she being randomized to? Chemotherapy plus endocrine therapy, or endocrine therapy alone with the CDK4/6 inhibitor ribociclib. We're going to answer higher risk patients, but they're endocrine sensitive. Does the endocrine sensitivity make the difference for finding even a larger group of patients who don't need chemotherapy? Finally, not all assays are the same. I got challenged by the earlier speaker. I will answer one of the questions. Here's how EndoPredict is derived. You use tumor size as stated, nodal status, and then the molecular score, the genomic score. But this score of high versus low is being driven by nodal status. 2/3 of the score is being driven by nodal status, which means if you're node positive, you have a much higher chance you're going to be high clinical risk. We've already shown from responder that you can be 1 to 3 positive lymph nodes, and 85% of patients won't get chemo. If you do an EndoPredict and it's high, you're going to think she needs chemotherapy. I just think it's over-treating patients, especially who are node positive. And it's hard to be node positive and have a low EP-Clin score. The huge majority of the women will have a high score. And I think they're just going to be over-treated. They have a worse prognosis, no question about it. They don't have prediction. There is no predictive data. There's no randomized data from EndoPredict that shows who does and doesn't benefit from chemotherapy. And when we look at TransATAC and look at the EP-Clin scores from TransATAC, the node negative, 27% are high, but the node positive, 81% are high. It's the wrong way. It's overdiagnosis of high risk. You're going to give chemotherapy, and there's no evidence from responder that they're going to benefit. Back to these data. I just think prognosis is very important, but prediction is where we're at here. So my final slide, I apologize that I'm over. Data from TAILORx and responder have demonstrated that the recurrence score test can identify the majority of patients who are hormone receptor positive and HER2 negative, up to 3 positive lymph nodes that can safely forego chemotherapy. The long-term follow-up of TAILORx, there's many more events. No difference in the postmenopausal and the premenopausal. We're still seeing that 21 to 25 group get a lot of chemo benefit. 16 to 20, they've got to be higher clinical risk. We need to continue to look to studies to improve the 21 gene recurrence score, as we do with all of our genomic assays. And the ongoing and future clinical trials, I will help us to optimize our therapy, not only for chemotherapy, but also surgery, radiation therapy, and when we can think about using a CDK4/6 inhibitor. And I thank you very much for your attention.
Thank you very much, Dr. Russell, for this very comprehensive talk. Because we are running late, is there any burning questions or? Yes, Dr. Unch.
Dr. Unch has a question?
Question or comment?
A question.
Okay.
A simple question.
Simple one.
In the study design which you have shown, which is a very clever design to randomize patients between chemo, endocrine, and then just, quote by quote, ovarian function suppression plus endocrine. I forgot the name.
Offset.
Offset.
Offset chemo.
Not offset, offset.
OFSET.
Okay.
Ovarian function suppression endocrine. Okay.
So I think if I saw the inclusion criteria correctly, you might have an overlapping patient population who might be candidates starting next year with ribociclib, according to the Natalie study.
So
are you taking that
yes.
into account?
So ribociclib abemaciclib and ribociclib will be allowed on the trial.
Okay.
But you have to say that before the randomization.
Okay.
So they will have an equal number of patients in both arms that have a CDK4/6 inhibitor.
Well, the point I want to make, just a point, a scientific point, almost 90% of the patients in the abemaciclib Monarch E study and also in the ribociclib Natalie study have had neoadjuvant or adjuvant chemotherapy.
Correct.
So meaning in one arm you're going to allow, because you're going to allow to have CDK4/6 inhibitor without chemotherapy, which is not standard of care.
Ribociclib's not yet standard of care in the adjuvant setting,
it will
right?
be. Well, it will be next year.
Hopefully, yeah.
Yeah.
Right. I think this is Z11. Z11, everybody got chemotherapy, right? So, and then it was whether we should do axillary lymph node dissection or not. That's not the standard of care to give everybody chemotherapy. We still do sentinel lymph node biopsies on these women.
But the point I want to make, as for the moment, CDK4/6 inhibitor therapy is in those patients. Number one, it's already possible in Europe with Abema, and starting next year with Ribo. The standard of care is neoadjuvant or adjuvant chemo followed by CDK4/6 plus endocrine.
So they did that because they wanted to populate both those trials with very high-risk patients.
I know.
So they, based on not having an oncotype, you could actually get into the Natalie trial based on a recurrence score of 26 and above and be N1. So they did add it a little bit onto the trial, but your point is well taken. We are now going to embark on the possibility of women not getting chemotherapy and then ending up with a CDK4/6 inhibitor. I agree with that.
Thank you.
Thank you very much, Dr. Russell, for your excellent presentation.
Thank you for allowing me to come.
Thank you, everybody.
Lunch for half an hour.